This is Dr. Kannagwal, the convener of the IAGES PrimeTime. Warmly welcome you, all the delegates, both in the Doplexes platform and various social media platform of the Indian Association of Gastrointestinal and Endoscopic Surgeons. Ladies and gentlemen, may I have the honor of inviting the President of the Indian Association of Gastrointestinal and Endoscopic Surgeons, Dr. L.P. Thangavelu. Most of us know him. As a matter of honor, it is my responsibility to introduce the President to you. Professor L.P. Thangavelu passed out with honors from Coimbatore Medical College, and later he got trained at multiple places in the Europe. He was the very early person to adapt laparoscopic surgery as early as 1990. Can you hear Dr. Sonalika? Sorry about that technical challenge. Sir, President, sir, you please disconnect the iPads and iPhone. Thank you, President, sir. Thank you, President, sir. And friends, I'm sorry for the technical glitch. As we were in multiple places across the country, there is some challenge with that. I'm sorry and apologize for that. Thank you for setting things up in right perspective. So, friends, ladies and gentlemen, I have the honor of inviting the President, Dr. L.P. Thangavelu, sir, who is the National President, who himself is an eminent pioneer laparoscopic surgeon, who brought in laparoscopic cholecystectomy as early as 1990 to his part of the country. He was the first to do the laparoscopic cholecystectomy in that part of the country. And later, he has been along with various portals of the IAGES, so that contributing to various academic programs, and he has been part of all the teaching programs of the Indian Association of Gastrointestinal and Endoscopic Surgeons. IAGES PrimeTime is a unique initiative where IAGES forges relationship inside the boundary of the country as well as out of the boundary of the country, and we go international as well. We have been addressing to various topics by leaders of various societies across the country as well as out of the country. Now, may I have the honor of inviting Dr. L.P. Thangavelu, our National President, to welcome all of you. Over to you, sir.
Am I audible, Thangavelu?
Perfect, sir.
Okay. Charles Kriplani, Professor Ajay, Kriplani, Dr. Satish Mida, Dr. Kannagwal. Good evening, all of you. I'm extremely happy and honored to be in this online program today. It's a very prestigious program for IAGES. This prime time is a star program of IAGES, watched by several thousand surgeons in India as well as throughout the world. And today, IAGES was founded in the year 1993, and today the live membership number is nearing 9,000. So now the primary association for minimal access surgery in India, and it has thus various academic initiatives and activities. The International Association with the European Association of Endosurgery, when I was a guest to you, Dr. Conde, way back in November last year. You have done after the COVID. You have conducted a WCS World Congress at Barcelona, and I thank you for the excellent hospitality extended to me and my president at the time, Sunil Popat. And thank you for that hospitality once again, Dr. Conde. And we are having international connections and associate. We are associating with various organizations internationally. We are having once in 3 months online program with the Association of Laparoscopic Surgeons of Great Britain. And similarly, we are having periodical programs throughout the year with SAR countries. And we are a very important member in IPSIS, Dr. Charles, and we are going to have, we are going to conduct the World Congress for WCS 2024. It's November, all arrangements started now, and so I am utilizing this opportunity to welcome you for that World Congress Conde, and we are very happy on behalf of IAGES. We welcome you for that meeting. It's a very important meeting, and similarly, next year in Coimbatore, southern part of India, we are having our annual national congress, February 9, 10, 11, 2023. Please make a note of these dates in your diary, Dr. Conde, and I utilize this opportunity to welcome you for our annual national congress at Coimbatore, a very popular place known for minimal access surgery in India. Everybody knows Coimbatore, and I'm very happy to welcome you for the annual national congress once again, Dr. Conde. IAGS is doing wonderful academic activities. The fellowship program is the primary, prestigious program for our association. This has been started several years ago by Professor Ajay, who is right now here, and I used to call him as father of fellowship courses in IAGS. And we do basic laparoscopic surgery. We train nearly. We have already trained more than 4,000 surgeons for basic laparoscopy, and they are doing excellent work throughout the country. Even in the remotest places, they are doing services. Even the people living in remote places, they are having access to the minimal access surgery facilities. Like that, fellowship program for advanced laparoscopic surgery also we have got for subspecialties like upper GI surgery, biliary surgery, oncology surgery, hernia surgery, and we have got several robotic surgery. So we have got fellowships for advanced laparoscopy who are well versed with basic. If somebody wants to specialize in advanced laparoscopic surgery, we have got several fellowship programs. Endoscopic services also. We are training many surgeons. More than 1,000 surgeons have been trained with endoscopy, both therapeutic and diagnostic endoscopy. And today, in our prestigious prime time, two excellent speakers are participating. One is the Spanish Association for Surgery President, Dr. Charles Conde. Another is our very important personality in Indian minimal access surgery, Professor Ajay Kriplani. Both are talking about, one is Dr. Conde is talking about current evidences in mesh fixation, and Professor Ajay Kriplani, the challenges in mesh fixation. With these few words, without without interrupting you, I am happy to hand over the mic to Professor Kanagavel.
Thank you, President. May I now have the honor of inviting Dr. Satish Mida, our National Honorary Secretary, to read the citation for Professor Morales Conde. Over to you, sir.
Good evening, everybody. Welcome to this another edition of Prime Time of IAGES. To introduce and read the citation of Professor Salvador Morales Conde, who is a general and digestive surgeon, Chief of Unit of Innovation in Minimal Invasive Surgery, Upper GI and Bariatric Surgery of the University Hospital Virgen del Rocío in Seville, Spain. And he is the head of the General Digestive and Laparoscopic Surgery Unit of the Hospital of Quirón Sol de Sogado Quirón in Seville, Spain. He is an academic surgeon, associate professor of surgery in the Department of Surgery of University of Seville, and the academic fellow of Royal Academy of Medicine and Surgery in Seville and Lugo in Spain, with a lot of international activities. Namely, visiting professor of School of Medicine in Northeastern National University in Argentina, faculty of training program of the University of Malta, faculty of IRCAD in Strasbourg, France in 2005, and in Barretos, Brazil since 2012, faculty of Italian School of Abdominal Wall Surgery and honorary member of Society of Surgery of Cuba and Venezuela. He has an important activity in surgical societies, being vice president of the Spanish Associations of Surgeons, president of the Spanish chapter of endoscopic surgery of the Spanish Associations of Surgeons from 2010 to 2014, and president of Spanish chapter of abdominal wall and sutures of the same society from 2006 to 2010. He was also the board member of Spanish Society of Bariatric Surgery. At the international level, he is the General Secretary of the European Hernia Society, and he was board member of the Technological Committee of European Association of Endoscopic Surgeons. Dr. Conde is involved in training and education as the Director of Training Program of Endoscopic Surgery of the Spanish Association of Surgery and the founder of the online platform of training education on the hernia surgery, Hernia EU, organized several workshops every year. He was the president of European Congress of European Hernia Society in 2008, chairman of the Joint Congress of the European Hernia Society and American Hernia Society held in Miami in 2018. President of Congress of Spanish Society of Bariatric Surgery in 2017, chairman of Winter Meeting of the European Association of Endoscopic Surgeons, and honorary president of MESH 2018 held in Paris in 2018. He has also organized European Congress of European Associations of Endoscopic Surgeons in 2019. His activity as a researcher is based in innovation in minimal invasive surgery, abdominal wall surgery, bariatric and colorectal surgery, publishing over 100 articles in peer-reviewed journals with a high impact factor. He is also director of research of Royal College of Medicines of Seville. He has been involved in several international guidelines and has participated in different multi-center studies as investigator and as member of steering and safety committee. He has been principal investigator of several research projects and private and public financial support. He has several scientific and social recognitions, and his works have been awarded in several national and international congresses. He is recognized as one of the best surgeons of Spain in credentials, journals as Forbes, and one of the most influential persons in Andalusia in Spain. Dr. Conde, MD, PhD, has no financial affiliations that would affect the contents of these presentations. So it's pride privilege for me to have Dr. Conde with us this evening. So I welcome you to give us your presentation on a very important and pertinent topic, because on the fixation strategies in surgery, the current evidence.
Professor Salvador, it's yours.
Okay. Well, first, thank you to the Indian Association of Gastrointestinal Endosurgeons. It's a real honor for me to be with you. Always a pleasure. It was really exciting to see the Indian delegates during the World Congress in Barcelona last November. It was exciting to share finally after the pandemic, at least some time. Even we don't have much time and we don't have as many delegates because still we were involved in the pandemic. So I hope that for sure in 2024 in Calcutta, we will be a better situation in the world and we will be more and more people getting to India, because I think we deserve it as a surgeon to start sharing again friendship and science. So thank you very much for the invitation. Thank you, Professor Tangevelu, Professor Gavel, and Professor Mida for the nice, very nice introduction. And as I told you, it's a real honor to talk about this topic today. So what I'm going to cover I think it's very, very interesting topic, and it was very wise to put it in the program because there is so many questions. And last Monday, I have a workshop in my hospital with people from different countries, from different countries in Spain, in Europe. We have people from Greece, Romania. And one of the topics that we talk about during the meeting, because it was a workshop with 10 surgeons, it was again, once and again, about how to fix meshes and how we should be the policy of fixing meshes. So I think it's very, very, very important. Also yesterday, I was trying with some engineer, some system, robotized system for meshes, some robotized system for minimally invasive surgery. And we have also an important discussion about the role of this robotized system for mesh fixation. And I will give you my idea. We have a nice conversation about this topic because it's very, very a hot topic. Of course, when we talk about hernia meshes and fixation in minimally invasive surgery, we have to distinguish between inguinal hernia and ventral hernia, because the policy that we follow is going to be totally different when we face an inguinal hernia and a ventral hernia. I think if we talk about mesh fixation in inguinal hernia, we really have to focus and see what is the evidence, because there is a lot of evidence, and that evidence have been collected in the international guideline for growing hernia management, that it was published with the participation of 7 surgical societies around the globe. So we all get together, and there was 55 experts that we worked together to analyze all the evidence. And I have to tell you that now we are working on the update of this guideline. So in this guideline, if you analyze what is written regarding open surgery, even that still the people fix it with the strong fixation with the stitches, we have to know that fixation with glue or a traumatic fixation with self-fixation meshes, it really works. It really works. And on the other hand, one of the most important things, it may reduce and is related to pain. So it's important to have in mind that also in open surgery, mesh fixation should be atraumatic when we do a hernia repair. The topic about laparoscopy is a little bit more easy on one side and more complex, because we have a lot of information in the literature, and there is a statement in that guideline saying that TEP repair most of the time doesn't need any fixation at all, so you can get out of fixation. On the other hand, another thing that we know, that's a traumatic fixation, that means either no fixation or glue really reduce pain. So there is no, with the same rate of recurrence. So if we have the same rate of recurrence and we can avoid fixation with Tacker, we have to do it. And the other message from this guideline is that basically large direct hernias, M3 in the classification of the European Hernia Society, are the only one that really need to be fixed. As I told you, I was with some people, some engineer discussing about robotized system, and they told me that they thought it was a good alternative to avoid Tackers, these robotized and do fixation with this robotized system. My answer was really clear. Well, this is not a question of a way of getting out of Tackers. They use the robotized system because the thing is, like during laparoscopic inguinal hernia repair, you don't need to use Tackers at all, and you don't need any other thing to fix. And the only thing that you have to have in mind that maybe you need some specific case of large and multi-recurrent, you need to have some fixation. So have this in mind. We are dealing in most of our hernias, we are dealing in laparoscopy either with no fixation or with the fixation with this glue. So basically, if you see what we have, there is something important to analyze. So we have several options to fix meshes. We have Tackers, we have no fixation, as I mentioned, and we have a glue. So out of this message from the guideline, the question is, which one we should use in the clinical practice? We have to have in mind what I said, either no fixation or a traumatic glue. But how I do it in the clinical practice? What about no fixation? I have to tell you something about no fixation. There is a lot of information that you can avoid fixation in inguinal hernia repair and have no fixation at all. But one of the things that I always have in mind that is totally different to have a flat mesh that you lie on that area than using an anatomical mesh. This is not evident. This is my experience. I feel more comfortable using an anatomical mesh with no fixation than a normal flat mesh. Even there is evidence, I like to use this anatomical mesh because stay there and adapt to the vessels and to the cord, and I have the feeling that I have better traumatic fixation, better no fixation in this area. So my question is, my recommendation is no fixation works, is a good alternative. There is evidence to no fix a mesh and just leave it there during a TEP or a TAPP, but I personally, and this is the evidence, this is my experience, I prefer to use an anatomical mesh when I don't fix the meshes. So what will be the role of Tackers? What I'm afraid, I remember that at the beginning of the era of laparoscopy, there were many surgeons using a lot of Tacker to fix the mesh. And on the other hand, I used to see surgeons closing the peritoneum in a TAPP using Tackers. I still see in some places that they do it, and my advice is please don't do that, because our goal as a surgeon who do abdominal wall, who do inguinal hernia, we try to get to avoid Tackers, and what we cannot afford, we cannot permit today is to use Tacker to fix the peritoneum. The only indication today for Tackers, follow the literature, follow the evidence, the current evidence is direct hernias. So a hernia like this that is an M3, I know it's an M3 because it's a medial hernia. You see the epigastric vessel, and the opening of my endoclinch usually is around 3 centimeters. So you see that this is around 3 centimeters. In these type of cases, is the only cases in which I will use a Tacker here in the Cooper. I use another one in the rectum muscle, another one in the upper lateral, in the upper side. So never place a Tacker in this area down here. So if you use a Tacker, use it in these 3 positions, but not in any other places. So I use it only in this large direct hernia. The other question is, you decide to use a Tacker, you should use a permanent or you should use an absorbable Tacker. And my recommendation is to use absorbable one, because what you want is to fix the mesh during the integration, and they will be gone at 6 months and the mesh will be properly integrated. So you see in this case, you see how I place in this case is a PermaFix, is one of the type of absorbable fixation device. We have secure strap, we have PermaFix, or we have the AbsorbaTac, and you fix one over there in the Cooper ligament. Then I place another one in the rectum muscle, and then you place the last one in the lateral. Well, this is removed, so you need good pressure from the outside here, and then you can place another one in the lateral upper area of the mesh. And this is the 3 point in which, in case you use Tacker, you have to place, and those cases are the large direct hernia. But one of the things in these direct hernias that you fix with Tacker, absorbable Tacker, is you need a good support. So how do you get good support? What do I mean with that? I'm not going to close the defect. There are some surgeons closing this large defect, but what I do when I have this large direct hernia, as you see in this video, is that when I reduce the content and I have the fascia transversale, what I do is I use an endoloop to plicate this fascia transversale, which decrease seroma, but also give a better support to give you a better support to be able to have a better integration of the mesh. There are some surgeons who use a Tacker to tack the fascia transversale to the Cooper ligament. I don't support that idea, because in M1 and M2, you don't need that Tacker, and you can avoid Tacker. And what you have to do is duplicate, because if you use a Tacker to fix the fascia transversale to the Cooper, you could have pain in that area. So what I do is I place this endoloop in all my cases, and I avoid the use of Tackers. And for those large hernia, you will have a better support of the mesh for the integration. So you see how I ligate this the fascia transversale in these cases. So what about glue? If you will have a mesh, my idea of using glue is that what I want is to seal this area down here. That's my way of fixation. What do I mean with that? What I mean is, if I glue in this area, because I don't want the bowel, when the patient coughing after the surgery, go below the mesh. So the best way to fix a mesh is with glue. Even in those cases I told you I use Tackers, that is maybe 5% of my inguinal hernia, 5 to 10, I use both. I use Tacker and I use glue. And the reason is because the glue, the way I use it, I seal the area there, and I avoid the use of, avoid the bowel and the peritoneum go below the mesh. So you can use glue in these areas, as I show you, using drops with system like this one, that you push a little bit and you use drop in this area and fix the mesh. And when you desufflate, you avoid something going behind the mesh. So for that reason, and I explain you, I place the glue in the area in which you cannot use Tackers. And that's the reason why I like to use a combination in this large hernia. But also you can use glue in a spray, as you can see here. This is fibrin glue. I like better this idea of having a film of glue in this lower part, and this way you avoid the bowel going behind the mesh. And this is the way I glue the mesh to this area. And in case I have a direct hernias, in this direct hernia, I add glue in this position. I'm talking of those M1 or M2 to avoid the mesh moving this way. So this is the way, once I finish in this line behind, I place some glue in this medial area to guarantee a proper fixation. And also an important thing is just see the way I place glue. I go with the glue behind the mesh because this is a mesh with a small pore. So you see how I glue that area and I glue the medial part because it's a direct hernia. So you see this combination of glue, tackers, and spray. And the other added value of using this glue in spray is there is an added value because some of these agents have some hemostatic effect. And that's the reason why sometimes I prefer to use this glue in spray to get this hemostatic effect. So this is the whole combination of tackers, no fixation, absorbable tacker, no fixation, and glue. And you can see here that this is the way I work. TAPP need a stronger fixation, and you see here how I place here even the L3 hernia in TAPP for fixation. It's totally different from a TEP because in TEP the space is is less dissected, lateral, so you need less fixation. So my recommendation is that if you have a large hernia, you should use a small pore meshes. But if you use a very small hernia, you can either use a small pore or large pore. And as I told you, no fixation or glue is the solution. And in the large hernia with a small pore, you should use absorbable tacker together or with glue. And the only thing that if you have a Sportman active person, the only difference is you should try to use large pore in most of the cases, except in the large cases. And in these cases, try to avoid, except in the very large hernia, the absorbable tacker. And that will be my algorithm. And just remember what I told you. Don't use tacker to fix the peritoneum. Now, I think the hernia surgery is more democratic. What do I mean with that? There are more surgeons who can do it because at the beginning, sometimes it was a challenge to close the peritoneum for most of the surgeons because you have to tie twice at the beginning and at the end. Today, with the barbed suture, you really have decreased you really have increased the number of surgeons who are doing this technique because barbed suture allow to avoid any knot at the beginning and at the end. The only thing, use it the proper way, go twice at the end to avoid an important length of the barbed suture exposed to the bowel because you can have some adhesion. So don't use tacker to fix the peritoneum, use a suture, and it will be easier and faster if you use the barbed suture. So I covered the inguinal hernia, and now I'm going to go into ventral hernia. Well, you have two way of fixing the mesh in ventral hernia repair by minimal invasive surgery. You have absorbable and you have non-absorbable. Basically, there are two differences between them. The absorbable one mainly is going to be absorbed after 6 to 12 months, but the main difference is described in this paper from Holinsky in 2010. You can see in this diagram that the strength of PROTAC, of permanent fixation, is higher than absorbable fixation. And that's the reason why we've been using absorbable permanent fixation in our cases, because we need a strong fixation. You see how suture is even stronger than Tacker. But this is what really worries us as a surgeon. That's the reason why absorbable Tacker were not so popular at the beginning, because you didn't get the strength needed. But the other side of the coin is this, that is also published in this paper. You see the P, that is PROTAC, the number of adhesion to PROTAC is so much higher. And you see the difference, a significant difference was absorbable fixation device. You can see the amount of adhesion with this absorbable fixation is less. So you have a system that produces less adhesions, which is great, but the strength is not as good. So how do we face that? I will tell you how we managed to do that. This is the problem of Tacker. So I don't like to use Tacker. I really, the old Tacker, and this is a real case that I reoperate. This is a patient that I operate and then I reoperate a few years later for another, I think it was a gallbladder, and you can see those adhesions directly to the Tacker. So it really worries me. Even the systematic review and meta-analysis says there is no difference on the results of absorbable or permanent. We know that the strength of Tacker is higher. So I will give you a little bit of history of what we think about that. And this is because the technique of fixation is influenced by the technique you're doing. So the technique is very important. We cannot say ventral hernia, you have to do absorbable or not absorbable. Which type of repair are you doing? This is very, very, very important. I will show you something. So in the history of ventral hernia, but minimal invasive, there is this concept of IPON technique. IPON technique is placing a mesh intra-abdominally, breaching the defect, and that's the reason why during the years it became not popular at all, because surgeons didn't like too much to do this IPON breaching the defect. We need a large mesh to breach the defect. And the most important thing, since there is a hole in the middle, you need to use a strong fixation. And that's the reason why Tacker were so popular, because we have from the literature that we need as much strength as possible to fix the mesh when breaching with the IPON. And that's the reason why I was using those Tacker for many years, because I was breaching the defect. There was no option at that time. There was no discussion that Tackers were needed, even producing those adhesions. The other problem that even that we have this strong fixation, you can see in this CT scan of one of my patients of all times, how the Tacker move. And sometimes we have this bulging because we didn't close the defect. So at the end, everything end up in the middle, inside the sac, even that we don't need to reoperate those patients. And in fact, we call it pseudo recurrence. We have patients with these pictures, and you see how one Tacker is here, another one it was here for sure. This Tacker should be here, and this Tacker should be here, but all move inside. So this is the problem of IPON, is breaching, large messes, permanent fixation, bulging, and that's the reason why cases like this with not a real defect like a heel, in which you don't reconstruct, we start having doubts if it was a good indication, these cases with this type of hernia, in which there was not a real defect, it was just like a heel. It was a weakness of the abdominal wall. And on the other side, since we were leaving the sac inside, sometimes the seroma was too heavy and disattached the Tackers, as you can see in this picture for one of my patients at that time. And you can see one Tacker here doing the double crown technique, another one here, and this that is disattached because of the seroma, that the liquid was pushing the mesh toward the inside. So this is what we had in 1993 and basically during the 90s and the early 20s. So what have been changing? Well, the important first change was in 2007 with the suturing technique, the idea of suturing published by Eliche Lala, in which they will start closing the defect. And I have to admit that at the beginning, this IPON plus of closing the defect, I didn't like at all. But the literature have demonstrated that the IPON plus reduced seroma, reduced recurrence, reduced bulging, and the patient was more satisfied, and especially, and even in 2019 in Annals of Surgery, have been published a multi-center double-blind randomized control trial in which the quality of life of the patient by closing the defect was better than the traditional IPON bridging the defect. The problem is that this technique was described, as you see, it was described by just closing the defect itself, just using this spider tissue and joining the two edges. This is the only case I did by this way. And in fact, I was in this side of the face-to-face, because I didn't believe that this was the solution. So then what we did is we did a running suture. We did start doing a running suture, and then I moved into closing all my defect. But I was not just closing by defect. I was included the whole weakness, the whole incision, and also the diastasis in case of a primary hernia. And I started doing this running suture, joining together the two edges and doing a reconstruction of the linea alba. Another thing that we observe is that we follow our patient, and you see that after 1 month in a CT scan, the two rectum muscles were joined, but after 1 year, they will open back. So this way of closing the defect was a good idea, but it didn't work, especially in all patients from 5 to 10 centimeters. So we start thinking we need to do something different, because if you join together the defect, the fibrous tissue of the defect of the peritoneum, this suture is not going to allow to heal together the two edges, so with time it will open back. And that's the reason why we published in 2018 the technique that we're doing, and there are many surgeons in Spain and in many places start doing it, is the LIDA technique. Basically, and this is important related to fixation, you understand why. We open the fascia, the posterior fascia of the muscle. By this, we decrease the tension in the midline. And it will, since we decrease tension, we have less pain and bulging. So then we bring together in the linea alba this, the medial part of the posterior fascia, including not only the defect, also the weak area and the diastasis and the whole incision. And also, the most important thing is what we close in the linea alba is not fibrous tissue, it's not peritoneal, it's a tissue that is going to heal together. And now we start with the fixation. Look at this. It's not the same to place a mesh directly to the peritoneum than to place a mesh over the muscle that's been peeled. So you will have an inflammatory action and a better ingrowth. So we are dealing with a concept of biological fixation. So we are giving the chance to the mesh to have a better fixation by itself, by the integration. So that's the beauty of this technique, that you increase the biological fixation of the mesh. And in fact, look at, this is the IPOM Plus, the traditional way of closing. You see after 1 year how the midline opened, and with the LIDA technique, after 1 year, stayed in place the linea alba. So this is the way we do it. You see how we are opening the muscle in the linea alba. You see how the muscle is exposed in both sides. And once the muscle is exposed, you see how we go around the hernia, around this small defect, and around this umbilical hernia, primary umbilical, together with all the diastasis behind. And once we do that, we start closing together in the midline, the medial side, the medial part of the fascia. And what we are going to join together when we pull is not the edge of the defect, it's going to be the edge of the muscle, the edge of the fascia, and these two are going to work together. So I decrease the intra-abdominal pressure, we join together, and the two structures are going to heal together. And the mesh is going to be in contact with this muscle that we expose. So the important message, and that's what I want to get, is the strength. So we don't need as much strength. We don't need as much strength because we have the whole support of the linea alba reconstructed. We have a mesh that is going to integrate, and we can decrease the strength of our fixation, and that's the reason why I start moving to absorbable fixation. So now we are so happy that in most of our cases, we are using absorbable fixation device. And what does it mean? That means that we don't have adhesion out of the Tacker, and we are going to we don't need that strength, and we have less problem if this patient ever need to be reoperated for some reason in the future. So that's the reason why the LIDA technique have become very popular in our group, because you can reduce the strength of fixation and using absorbable fixation device. But on the other side of the coin, that is for less than 10 centimeters, but for those more than 10 centimeters, we are doing laparoscopic component separation. And in these cases, what we do a TAR. We do a posterior component separation, and we do the TAR. We've done already all the dissection, and then we close the posterior fascia. I'm not gonna go on the technique because it's not the topic. I'm closing the posterior fascia here. You see how I'm using, you see the TAR on the lateral side where the mesh is going to be placed. You see how I'm working this new space that I created. And once I close the posterior fascia, I start closing the anterior fascia. But what I want to show you is that once I close the anterior and the posterior fascia, in this retromuscular space, I place a mesh that I don't fix it because it's a large piece of mesh. And sometimes what I do, I just glue. So in this retromuscular space in which you can use standard polypropylene mesh, a large polypropylene mesh, most of my time I don't use any fixation at all in this component separation. So to start finishing, you see that in less than 10 centimeter hernia, I use the leader technique with absorbable Tacker, and sometimes I added some glue. But the question is, what will be the role of robotic in this area? And I can tell you that in this road towards the new way of doing minimal invasive surgery, maybe robotic surgery have some sense on getting rid of any fixation, and maybe the advantage of this robotic is doing a running suture. Maybe this is the good advantage. But today, with this way of fixing the mesh with the leader technique, the good thing is we get all this, we reduce the fixation with this absorbable fixation device. So on the other side of the different technique that we are facing today, we have those techniques in which a mesh is not placed intra-abdominal in those hernia less than 10 centimeters. And we have the ETEP, we have the Milos, or we have the lap supplé. I've done some cases of lap supplé, as some colleagues of my team are doing ETEP and trying to investigate the role of ETEP. And in these cases in which we do the retromuscular approach, we cross over to the other side, we close the defect, and in this case, most of our time, what the type of fixation that I use once I close the linea alba is to use self-fixed meshes. Self-fixed meshes like the ProGrip in this case, so that I don't use any fixation. So I place the mesh and then I close like in a TAPP. So I think that the way to face everything is that in inguinal hernia, barbed suture to use to close the peritoneum, no Tacker, glue or no fixation in most of the hernia, large direct hernia, use absorbable fixation device, but I use glue just to seal the space behind. Minimal invasive ventral hernia, I use the leader technique, open the posterior fascia, and for that reason, I combine absorbable fixation with glue. And in the retromuscular position, either a TAR or an ETEP or a lap supplé, you can use non-traumatic glue or self-fixing meshes. That would be the idea. And robotic in the future maybe have a role to fix the mesh doing a running suture, because the concept not of robotic, the concept of autonomous action. What do I mean with that? Autonomous action, and I will show you a video, is that this way of fixing, of closing the defect could be done by a robotic, but not run by you. I really believe that abdominal wall is a target for autonomous surgery. So you do all the dissection, and then at the end, you point where you want the stitches, and then the robot will do the running suture. And that will be the same once you have the mesh. So you can have the mesh, tell the robot the point and do it. Is it feasible? Look at this video that I get from the internet. This is not done by a human. This is you tell the robot follow the black line, and look at the robot by itself is doing that without any movement of the patient. So the surgeon need to say where to go, how to do it, but as if an automatic movement, the robotic will do it. And I think maybe in abdominal wall and fixation will make sense in ventral hernia. And for that reason, robotic will make a role in automation in the future of this surgery. So thank you very much. I hope you enjoyed the presentation. I'm open to have the discussion and to answer the question that you might have.
Thank you, Professor Salvador. In fact, it opened up a lot of new avenues, and we had a different perspective. And I'm sure the current evidence have definitely trying to answer the most troublesome questions which have been existing for the past 2 decades. Can I have the honor of inviting Professor Kriplani, sir, to give his viewpoints before we move on to the other questions? Over to sir.
Well, wonderful lecture, Professor Conde, and it was really very enlightening and very, very newer concepts. And you have a tremendous experience of doing both inguinal hernias and ventral hernias, and doing it with different techniques. And you have given us the abstract of your experience of decades. Now, I have got a few questions for you, if you permit me. What is your take in using progrip meshes in inguinal hernia? Because progrip mesh in inguinal hernia might actually eliminate more, give a stronger fixation of the mesh without the use of any tack, as you think it is popular, it is good for ventral hernia. Why not using progrip for the inguinal hernias? And why do you prefer the 3D mesh, and what size of mesh you use in inguinal hernia?
Yeah, regarding size, I use the large. I use the large mesh from the 3D. Is around 13 by 15 is the side, and this is the you need a large piece of mesh, no doubt about that. Regarding progrip meshes, my opinion is progrip mesh by laparoscopy is not easy to place, and the question is there is no need of fixation. Why doing the surgery too complicated? I'm talking that my absorbable Tacker is not even 5% of my cases. It's very low. And those are the very large direct hernia. So a progrip is not easy to place. You need to be an expert to extend it. And you take so much time when you just can't place a mesh and forget it and not using any fixation at all, based on the literature. And the literature is clear in that sense, that there is no need of using fixation. Progrip in ventral, as I show you, is another world. But in inguinal hernia, there is no need. I even did some cases with adhesive. That is another meshes with glue, difficult to extend. And so I would recommend, in my personal opinion, is that no fixation is a real option.
And this 15 into 13 centimeter mesh, what mesh you are using, Professor Conde? You are using the heavyweight mesh, 80 grams, or using 50 grams, or you're using the light ones?
I use a small pore. I use the small pore, and I will tell you why. Based on the guideline published in 2018, there is a slight difference. There is no difference in chronic pain regarding the pore of the side of the pore of the mesh. And this is what the guidelines say. The only difference between large pore and small pore meshes is a slight better functional recovery of the patient during the first 2 to 3 months. For that reason, I always use a small pore, except in a sportman patients that, for example, this week, Monday, operate a patient that wants to do a marathon in 2 months, and I use a lightweight mesh, a large pore. And this is the only one, because there is no difference. There is no long-term difference in terms of chronic pain based on the literature. So that's the reason why I use as my standard of care is using a small pore mesh, because it's easy to manage.
But will you agree that if you use a lightweight mesh, then the chances of recurrence, particularly in the direct hernias and large inguinal hernias, become more? And in that case, when you are using a lighter mesh, will you consider the fixing these meshes in those patients?
Yeah, what I will consider in the large medial hernias is I will never use large pore meshes. I would prefer in those cases to use a small pore, because the strength of the mesh, it will be better, because the flexibility of a large pore, you will give more chance to have recurrence in those kinds of hernia. So I totally agree with you that in large direct, you should use a small pore hernia, heavyweight.
Professor Conde, when we go back and view the Reeve Stopa technique, and which was the giant, coverage of the visceral prosthesis by the prosthesis, we all know that even despite using a very large mesh in the Stopa series, there was some displacement of meshes, and this displacement of meshes were the reason for recurrences in Stopa's case. Do you think that by using these 15 into 13 centimeter meshes, which are much smaller than what Stopa used in his bilateral giant visceral prosthesis repair, some of these meshes might migrate and expose the weak area for a recurrent hernia?
Well, I haven't seen it, but yeah, but I consider that those dissections were higher, so this space is more limited, so the possibility of moving is less. That's the reason why when I do a TAPP, some surgeons recommend to open a big gap in the peritoneum. I do a really small one. I do a small one just to introduce the mesh, so the dissection itself will maintain the mesh in place. So I only dissect what I need. When you do a Reeve Stopa open, you go from up and you do a wider dissection. So I think it will be interesting just to dissect, to have the tip of mind of the area you need to dissect, because the dissection will limit the movement of the mesh. And I think that's important. I don't know if you agree with that.
Thank you very much. Thank you.
Thank you, Professor Kriplani. Professor Morales, I have a question. In LIRA procedure, when you try to reconstruct the post-rectus sheath, don't you think we are adding the burden onto the post-rectus sheath of the weakness of linea alba? Of course, there is a mesh is going to support it, but are we not reducing the PRS width, Professor?
No, we are not creating a weak area. We are giving a strength to the linea alba by joining together the fascia. And just remember that, in my opinion, what really get the strength is the anterior fascia. So you are joining together the anterior fascia by doing this technique. So you will have even more strength in the linea alba by opening this fascia and joining together in the linea alba. The mesh will give support, and the mesh will give the chance of this linea alba to heal together and to maintain the linea alba together during years. And at the same time, the mesh will be integrated in the muscle and we will mimic the posterior fascia that you open. And this is the beauty of this technique.
So in your series, what is the outcome of LIRA and how long you've been doing this, Professor?
We've been doing this for at least 5 years so far. We have more than 150 cases. We are collecting the data. Of course, we have some recurrence, but less than 4% of recurrence. So we are very happy with the results that we are having.
And then the next question is the robotic mesh fixation. What you're telling was circumferential running sutures. It looks pretty much doable with little bit of effort with laparoscopy. Do we really stand to gain by running a stitch from all around in one go, Professor, without a knot in between?
I haven't done it so far. I see Michaela Piccoli from Italy done some cases, and I see some lecture from her. I think it's more theoretical than practical thing. I don't see many surgeons doing it, and I'm sure they show that they do just a couple of cases. But, and I tell you something, I think these autonomous actions of it will be the future, because you can imagine that You do all the dissection, introduce the mesh, you close the defect, you do the better dissection, and then at the end, you tell the robot, go there, 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 and the robot will do that. So this autonomous action, I do really believe that it will be an action of robotic in the future.
Absolutely. And this self-grip mesh, what I've talked about, doing a sort of retrorectus placement of the mesh. The polylactones, the one which gets into the muscle and the fascia, they get absorbed over a period of some time. Only the mesh remains according to the manufacturers of the mesh. Do you think it works to the advantage or it works to the disadvantage, Professor?
Well, if it's a disadvantage of this absorbable, the grip, no,
Yeah.
because the grip maintain the mesh close to the muscle and it will integrate it in the muscle. So I think the concept is great. The concept is great, but it's not easy to manage that mesh in laparoscopy. I'm telling you, in the ventral hernia is easier, but in the inguinal is crazy. I mean, it's not like go for it. And I don't know. I think Dr. Kriplani is laughing because he knows what I'm talking about, that it's not easy to manage that kind of mesh in this space. And in this, as a concept, is great, but it's not easy. And that's the reason why I mentioned that.
You know, Professor, we extensively use pro-grip meshes in inguinal hernia.
Really?
Pro-grip mesh is a very wonderful mesh because when you are placing the mesh, it works like a heavyweight mesh. It is more than 80 grams. And gradually its grips get absorbed. And at the end of 1 year, it is working as a lightweight mesh, so giving more elasticity to abdominal muscles. And earlier we used to, you know, we never fancied actually using lightweight meshes. Still we had the pro-grip in place and we were always using the 80 grams mesh. But once we started using the pro-grip mesh, as you rightly said, that it requires little training, little expertise, and little patience to initially do these cases. But when you see the results in the post-op periods, because you are using less tack only, you know, we use very minimal tacks when we are using this pro-grip. In the unilateral cases, we don't use any tack. And peritoneum, we always suture because peritoneum in the TAPP does not require tacks. The patients in the post-op period are so comfortable. They are so pain-free. All those complaints of, you know, heaviness in the groin area that we used to see with the 80 grams meshes earlier has disappeared. And this is our standard mesh. The problems with the mesh is, one, it is more expensive. And in India, cost means a lot. It's very, very expensive mesh. But those patients who have an insurance policy that support this mesh, we prefer to use this mesh. And secondly, as you rightly said, it is time consuming. It requires practice, it requires patience. And once you were impressed by the post-operative results of these pro-grip meshes, we started timing in our unit. There are 3 consultants and 5 fellows, and we decided that we have to gain experience in spreading the mesh, because the mesh tends to stick to the raw areas. And now we have evolved a technique that in the beginning, our mesh spreading time on one side was 8 minutes, which has now reduced to 2.5 minutes on each side by persistent practice and by patience. So,
no, I agree with you. With practice is make the difference and the experience.
But the post-operative comfort is tremendous. It's tremendous.
Yeah, but I feel comfortable because no fixation at all or gluing, because I don't use Tackers. And I think what we're saying, and I agree with you, that it should be the message of this webinar is, please don't use tackering in our hernia repair. I think it doesn't matter how you do it, no fixation, glue, or pro-grip, whatever, but don't use any more tackers. Maybe we will allow 5% of your cases because you have large direct. But the message is, do it whatever you want, but don't use tackers. And use large meshes, small pore meshes in direct. In the other one is your decision.
You know, Professor Conde, in our practice, majority of the patients, you know, do not come early for the inguinal hernia surgery. Most often, the inguinal hernia patients that we get are large inguinoscrotal hernias, which have become irreducible, and then they come back to us. Earlier, because hernia is a painless condition, so initially when the swelling occurs, they tend to avoid surgery. And only when it becomes irreducible or starts causing pain or it causes significant discomfort, so then they come for surgery. So we are very unlikely it is that we will see a bibanoseel or a hernia just going up to the external ring. a majority of our patients are either a complete inguinal scrotal hernia or irreducible hernias.
Yeah. We're happy here. They come earlier. That's good.
Thank you very much, Professor Salvador. I would request you to stay back for Professor Kriplani's talk, and then we can have a quick concluding remark at the end of Sir's talk. Can I have the honor of inviting Professor Satish Mida, sir, to introduce Professor Kriplani?
Thank you, Dr. Conde. It was very pleasant to hear Dr. Conde and new concepts in the fixation. And now I have the privilege of introducing our own Dr. Kriplani. Dr. A.K. Kriplani, Ajay Kumar Kriplani, is one of the most respected surgeons in the field of laparoscopic and GI surgery in India. He has been awarded many international awards and honors, including the prestigious Dr. S.R. Joglekar Award and Dr. N. Cheturaman Oration. He has trained many hundreds of surgeons in laparoscopic surgery in India and adjoining countries including Nepal, Afghanistan, Pakistan, etc. Dr. Kriplani has done his MBBS and MS from Ravi Shankar University in Raipur in Madhya Pradesh, now part of Chhattisgarh. With their experience of over 33 years, he is among the first few surgeons to introduce laparoscopic surgery in India and also advancing it to the next level. He was one of the first to perform laparoscopic adrenalectomy, splenectomy, and live donor nephrectomy for renal transplant in India. Dr. Kriplani is the past president of IAGES. Fellowship programs of IAGES were introduced by him and have been very popular and widely acclaimed. With the rich experience of 40 years to his credit, Dr. Kriplani has been associated with many prestigious organizations like Safdarjung Hospital, Delhi, AIMS, New Delhi, Indraprastha Apollo Hospital, New Delhi, Sitaram Bharti Institute, New Delhi. He takes keen interest in research and educational activities in minimal invasive bariatric and other related surgeries. So I have proud privilege of presenting you for the next talk by Dr. Kriplani. So over to Dr. Kriplani on challenges in mesh fixation, the way out.
Thank you, Dr. Satish, for this kind introduction. And as a matter of fact, it is indeed an honor today to be in this prime time and follow my lectures of Professor Conde. His very impressive lecture, his very informative lecture. And, we have learned so much, and we are thankful to him to hear that he accepted the invitation of IAGES and, spared his very valuable time and, enlightened our delegates from his experience and enriched us with his experience. I bring you compliments from Fortis Memorial Research Institute, Gurgaon, where I've been working for the last 8 years. And I'm not going to be, into very minute details of the laparoscopic procedures of hernia, but I'm going to discuss some very basic, very essential, very common problems that one faces during the laparoscopic hernia repair. As Professor Conde also said, that the primary endpoint of laparoscopic hernia surgery or any hernia surgery is to avoid recurrence, to have a zero recurrence rate. There are other secondary endpoints which include pain, wound complications, improved cosmesis, seroma, and functional status. But the primary endpoint always remains to have as less a recurrence, and the recurrence should be preferably, ideally, 0%. Now, we know that for all defects, and when I'm talking this lecture, I'm mostly talking about the ventral hernias and not inguinal hernias, because I agree with Professor Conde, though it is not 100% agreement, but it's a majority agreement that less and less stacks should be used in inguinal hernia. We use stacks only at the Cooper's ligament so that the mesh does not get displaced. And in large direct and indirect hernias, we use stacks. Otherwise, the inguinal hernia does not need too many tacks. So mostly my discussion will pertain to the ventral hernias. And we all know that all defects more than 2 to 3 centimeters meshes become essential today to prevent recurrence and obtain a 0% near 0% recurrence. Now, the Professor Conde described very nicely the tags which can be absorbable, non-absorbable. I will not go into the routine, but as I said, that minimum tags should be given in the groin area and in the ventral area. Ventral hernia, it is a double crown technique that we use. Sutures have been used in ventral hernia, and some people have used a combination of tags and sutures in ventral hernia, which we also continue to do, though there is a wow trial in 2013 with or without sutures, which showed that perhaps there is no difference in the outcome between only tagged hernias and hernias which have been repaired by Tacker and suture both. And adhesives have been used only in inguinal hernia and have not been found effective in ventral hernia. So, what are the various ways that we can fix the hernia? And mostly we are talking about laparoscopic ventral hernia repair. Fibrin glue, as I said, in ventral hernia has been discarded because of a very high recurrence rate. And retrospective studies have showed that absorbable and non-absorbable tags, there is no difference in the recurrence. And in the comparison, similar post-operative pain and similar post-operative recurrences have been found whether you use a metallic tags or absorbable tags. So what is the science behind the mesh fixation with tags? It is not just a stick given to a surgeon that he starts firing and he will get an optimal result. These tags have to be, we have to understand the ergonomics of tag, the science behind the tag, so that these meshes can be fixed properly, adequately, strongly, so that we do not get recurrence. Now, most of these tags we have to understand. The spiral metallic tag is only 4 millimeter deep. Most of these other tags are 5, 6, and 6.5, and a secure strap is 7 millimeter deep. They are all 5 millimeter or 4 millimeter wide. But even in the secure strap, though the strap is 7 millimeter deep, but the anchoring component is only 4.7 millimeter deep. So the entire strength in any tag that you are getting to fix the mesh is only 4 millimeter deep from the base, from the structure, from the muscle, from the sheath on which you are going to put the mesh and then tack it. So the entire depth is just 4 millimeter. This is an important fact you should remember. Now let's look at the anatomy of the anti-abdominal wall. Now this is the central part of the anatomy of the anti-abdominal wall. This is a direct hernia. This is the caudal portion with umbilical ligaments going towards the bladder, and this is the cranial component with falciform ligaments going. And the central part of the anti-abdominal wall has tremendous amount of extra peritoneal fat. And this fat is more in males than females because males have more visceral fat than females. And this is an important anatomical fact which you should remember while you are doing an IPOM procedure, which is the commonest ventral hernia procedure that is being practiced in the world today, and the most common procedure by most of the surgeons who have started their hernia practice. And this central preparietal fat on the anti-abdominal wall sometimes may be as thick as 4 to 5 millimeters, which is more than the entire length or entire depth of the track that we are using for the fixation. When we are going to put a mesh which is a which is a good material, then we must put this good material on another good material and fix it strongly if we want to have a strong repair. And this base material should be strong. It should be well vascularized so that when we fix it with a tack, there should be good anchorage with a good high bursting pressure. And this should be vascular so that there's a subsequent fiber ingrowth or fibroblast into the pores of these meshes, which further adds to the strength of fixation besides the tag that they are using. So with passage of time, the anchorage of the mesh to the posterior rectus sheath should become more and more and more, because there will be more fibroblastic ingrowth which continues up till a year. So the total strength at the end of 1 year should be more than what it is at the time of implantation of the mesh in an IPOM procedure. Now, if the preparietal fat is 4 to 5 millimeter thick and you put a tack which is 4 to 5 millimeter, and perhaps the length of the entire anchorage will be lost into this fat. And this fat itself, being avascular, will not allow any subsequent fibroblastic ingrowth. Therefore, whenever you're doing an IPOM, this or IPOM plus, this fat must be removed before you put the mesh on the posterior sheath, so that you actually put your mesh on strong vascularized tissue, which will allow subsequent fibroblastic ingrowth. That's a hernia recurrent after an open repair. You can see the mesh here. This is a 4.5 centimeter defect, and you can see the fat around it, which we are clearing for from the posterior rectus sheath. This you should get into an avascular plane, and you can see that that thickness of the fat of this preperitoneal fat posterior to the sheath is even more than 4 or 5 millimeter. So if you do not remove this fat, the entire depth of the strap will be lost in the fat, and the anchorage will be extremely weak, because fat does not support strong anchorage, because it will be wobbly. The mesh will not be strongly, will have a low burst pressure, and therefore all this fat must be removed. The strong posterior sheath must be exposed, and the mesh must be placed on this strong posterior sheath. This fat must be completely removed all around the defect, so that you get a strong repair. And nowadays, more and more often, we have started closing the defect, doing an IPOM plus. So this removal of the mesh also interferes with the suturing of these defects, and therefore it is very important to understand the significance of this preperitoneal fat on the anterior abdominal wall. Besides, there are other ancillary advantages of this dissection of the preperitoneal fat. This is another umbilical hernia, and you can see that we are removing this fat from the posterior rectus sheath, the preperitoneal fat, and we are dissecting both cranially and caudally. This was an umbilical hernia, and when we dissect the fat all around the hernia, and we are exposing the posterior rectus sheath, then we see a clump of fat here. And when we further dissect this clump of fat here, you can see it is a large defect which was completely concealed by the falciform ligament and its fat, containing a very large lipoma. So truly, it is almost a 4 centimeter defect, which if we had not dissected this fat, would not even have been seen. So it is very important, therefore, that one should understand the significance of this mesh. And in all umbilical hernias, the supraumbilical portion should be dissected, the fat should be cleared, and the mesh should be placed on a strong, well-vascularized posterior sheath. So when we say that tracks are 4 millimeter, the mesh also is about 1 millimeter thick. So 1 millimeter of your track, the depth is lost while you are fixing. And remember that when you clear the fat and now you are putting the mesh, and out of 4 millimeter, 1 millimeter is lost in the mesh. And besides that, the entire strap does not go into the anti-abdominal wall. How much tack will penetrate into the muscle will depend on the angle which this tacker is making with the muscles. If your tacker is absolutely perpendicular to the posterior rectus sheath, then the entire strap will sink into the muscle and you will get a fixation of 3 centimeter. But you remember that your cannula through which you are putting the tack has a fixed fulcrum at one point. And if you tack all around during the circumference of the mesh, then at all places you may not get an absolutely perpendicular angle to the anti-abdominal wall. And this is particularly true that then when you do an oblique penetration, then the entire tack will not go into the muscle. This is on the opposite side. Let's see, we operate from the left side, the port is there, and this is the mesh fixation. On the right side, you can see that these straps have completely gone, and the mesh is very nicely, very strongly, very firmly secured to the posterior sheath. But you see this strap here. As you come towards your side, as you come towards the port through which you are using the strap, it becomes more and more difficult to get a right angle, correct angle to push these tacks, and part of the tack may remain outside. So 1 millimeter is gone by the mesh, and the 2 millimeter is gone outside. So you get a very weak fixation of the mesh into the posterior rectus sheath, and with little force when the patient coughs or sneezes or struggles while it coming out of the anesthesia, this strap may just tear away and lead to recurrence of the mesh. And this is more true more on your side. You can see one strap completely, not remaining only to the mesh because you are not getting a proper angle. Now we are stapling on our side, and this has completely come out. And further, when you are stapling, you can see this strap here, this strap is half gone. And here, when you're trying to put more force, if you put more force into the tacker, then this tacker can cut through the mesh and again make a weak spot. So because of the anatomical fact that you cannot get an appropriate angle on the mesh anchorage to the anti-abdominal wall, when you are fixing this strap on your side of the mesh, sometimes it becomes very difficult to get a proper angle and get a proper penetration, and the anchorage may not be so strong. So remember about the thickness of the central fat on the anti-abdominal wall. Remember that the tack may become obliquely placed and may not give you a desired strength. The most difficult areas where you cannot get a length is the subcostal area, because you cannot dent the lower rib cage and cannot get a proper angle at the top of the dome, where is the area around the umbilicus and on the same side as the tacker cord. And bigger the mesh, the more difficult becomes the tacking on your side. If you are using a 15 centimeter wide mesh, it is easier, it is simpler, because you are using only 7.5 centimeter on your side of the midline. But you're using a 20 centimeter mesh, then your mesh is virtually reaching the anti-axillary line, and then it becomes very difficult to get a proper angle and get a strong fixation. Now coming to the transfacial sutures, which are a very common practice, started by Toy and Smoot long time back, and is a routine practice where most of the surgeons fix the mesh to anti-abdominal wall using transfacial sutures at minimum 4 corners, and it is most sutures are placed in the large defect for a strong anchorage, because fixing only by the tack is perhaps not a very good idea, and all surgeons use these transfacial sutures. When we remember that when we do multiple passages through the skin and then through the mesh, then we tie these sutures in the subcutaneous tissue where the knot is lying, there is a real risk of infection. And if you do not take my statement very kindly, then this is a patient who came to us after a sutured repair of the ventral hernia, and 8 out of 9 fixation points had sepsis. He was running high fever for last 6 weeks. He was on very high antibiotics. He had acute kidney injury because of the heavy antibiotics which have been using, and the CT scan showed multiple small, at 8 places there were small thick-walled abscesses like this, because of which the patient was toxic and an acute kidney injury, and it required a tedious, difficult laparoscopic surgery to remove the mesh in its entirety, along with the fixation of non-absorbable sutures, which were the site of infection in this patient. After removal of the mesh and antibiotics, his kidney function improved. He went home, and then he came 3 years later when he has gained a lot of weight and his hernia had become bigger. All these port sites were healed. The hernia had become bigger, and then we did a laparoscopic repair in this patient. So his 3 years of his youth were lost because of an unfortunate complication of sepsis happening in the mesh, which was fixed to the skin through a transcutaneous needle. So, besides increasing the possibility of infection, these transfacial sutures, they pass through full thickness of the anti-abdominal wall. So when you tie these sutures, they strangulate the muscle and the posterior rectus sheath. They strangulate the nerves, they strangulate the muscle, and they cause pain. And because the entry on the skin is one, and you are puncturing the muscles at 2 places, then the muscle which is present in the bite undergoes ischemic changes and may slough off, and there might be a recurrence in the area where you have tied the mesh. And you can see this is a patient who came to us after a laparoscopic ventral hernia repair somewhere else. A nice job has been done by the surgeon, very nicely anchored mesh, except that at all the 4 corner sutures, the muscle had sloughed away. He had a hernia here, he has a hernia here. You can see that here the mesh has shrunken, so the suture is here and there is a defect here. And here also, the defect is not coming in the same view because it's a wide field. So at all 4 anchorage points, he had hernia because of the ischemic necrosis of the muscle caused by transfacial sutures which were tight, and therefore he had 4 hernias instead of 1 now. So the challenges in the fixation of laparoscopic ventral hernia include central fat on the anti-abdominal wall, oblique placement of the mesh, particularly on the medial side and the subcostal area, transfacial sutures which can lead to mesh infection, can lead to muscle damage and herniation. So coming to the signs of stapling, signs of suturing, I'll just show you a quick video. We generally half roll the mesh and put a central stitch here. And when you are tacking this mesh over the posterior abdominal wall, there should be a counter pressure on the anti-abdominal wall to make the abdominal wall right perpendicular to the tack, so that the entire depth or entire length of the stape goes into the muscle, and they should be at adequate distance. And each time there should be a counter pressure for proper fixation to gain enough optimal desirable strength of fixation. And when you are using a macroporous meshes, you should not use a helical metallic tacks which do not have a head. In these patients, these straps which have a 2 point of entry are better because the pore size is high. This pore size is almost 2 to 3 millimeter, and a 5 millimeter helical tag which does not have a head will not be able to hold this mesh in place. So your strap should match the pore size of the mesh you use, exactly halfway turned, so we know that we have equally covered the mesh on all the sides. Unroll the mesh. We don't use any transfacial sutures, but make sure that there's an equal overlap of mesh around the defect on all the 4 directions. And if you're using a 15 centimeter mesh, then generally tacking on your side is not a problem. But if you're using bigger meshes, 20 centimeter meshes, because in a patient who is abdominal circumference is out 36 centimeters in most of the Indian patients, and 36 centimeters is on the higher side. If you use a 20 centimeter wide mesh, then getting a proper view and a proper angle on the medial side becomes difficult, which is not so in a 15 centimeter mesh. But there are occasions where a 15 centimeter mesh will not suffice. So you should learn how to handle these large meshes for the IPOM procedure. And after the mesh has been secured adequately by the strap, we do not rely on just 4 millimeter thickness, because we believe that most of the ventral hernia recurrences start on the table when the patient is being extubated and he's struggling while he's coming out. And that is one time if 1, 2, 3 straps are gone. So we use intracorporeal sutures. This is a 48 millimeter half curved needle, and this suture is 100 centimeter long, and this is introduced into the peritoneal cavity. And because Attibond is a slippery suture, the 3 knots are thrown and this mesh is fixed in place to the abdominal wall. This bite you can see is almost 4 centimeter long. So all 4 corners will have an intracorporeal suture fixation of the mesh to the anti-abdominal wall to augment the strength of the secure strap and make it so strong that when the patient contracts his muscles or sneezes or coughs in the post-operative period, then these sutures support it. And there's a geometry about these sutures. This suture should be in line with the 2 neighboring sutures. So it should be a complete square. And you do this way, if there's a good geometry, then it gives a very good strength to this mesh. So these sutures should be exactly in line with the suture next to them. That is how we fix them. But sometimes taking 3 bites from the Attibond becomes very difficult, and it may be slightly difficult for younger surgeons who do not who cannot practice 3 throws in a ethibond. So in these patients, we have now evolved another different type of suturing, which is easier for the younger surgeons to learn. Again, 4 knots are placed. You can see a big 4 centimeter bite anchoring the mesh into the anti-abdominal wall. And this is an intracorporeal slip knot or cinch knot. You can just put it simply through a surgeon's knot and just glide the knot onto the mesh, fixing it to the anti-abdominal wall. This is a wonderful knot. It is an intracorporeal slip knot. You can never over tighten this knot, so the muscles will never undergo necrosis. And this is easy to learn. This is easy to practice. This causes less pain as compared to the transfacial sutures. And again, in a 15 to 10 centimeter mesh, we will use 4 sutures. And if you use bigger mesh, if you use 20 to 25 centimeter mesh, then we will use more of these intracorporeal sutures to gain a strong fixation to the anti-abdominal wall, so that the mesh does not get displaced when intra-abdominal pressure raises because of the cough, because of the sneezing. This is the 3rd suture. And the sutures on your side, closer to your port, are more difficult to place. You can again see a wide 4 centimeter bite, and you can again appreciate the geometry of all these 4 sutures which have been placed to give a real good, strong anchorage of the mesh to the anti-abdominal wall. These intracorporeal sutures have very wide bite. They give strong fixation. They do not go through and through the muscle. They only fix it to the posterior rectus sheath. They are not very tight. So, you are not putting punctures on the skin. So it is less painful. And because the knots are intracorporeal, there is no risk of infection, and there's better cosmesis. So to conclude, that technical factors come into play for adequate exposure of the mesh, which must be in contact with the fascia with an appropriate overlap over the donut, or preferably you should do a diapom plus, close the primary defect, and provide adequate fixation. Once you start doing it, once you are determined that you have to learn these, they look difficult initially, but with patience, with practice, they can be learned, and all our fellows can reproduce these techniques. And patient factors which lead to higher recurrence rate are obesity and larger defects. Thank you very much.
Thank you, Professor Kriplani, for bringing in very interesting concepts and a better understanding about what we are trying to do on a day-to-day basis. May I have the honor of inviting Professor Salvador to give his comments, sir?
Thank you, Professor Kriplani. I think it's excellent lecture. We have a lot to discuss, but I would like to give you to have an answer about the future. I would like to see, how do you see the future of ventral hernia? I have so many discussion in Spain and in Europe about if the future of ventral hernia minimal invasive repair, it will be in retromuscular meshes or to do intra-abdominal mesh placement. My personal opinion is that the placement of intra-abdominal mesh is not over at all. I mean, there is something still have an important role, and for sure it will be more and more the role in the future. But I would like to know your opinion in this sense.
You see, Professor Conde, we have to see that when we serve the society at large, we have to have a procedure which can be easily learned, easily performed, with a low recurrence rate by a surgeon who has an average experience in surgery. The procedure, it is very important, should be reproducible. Even after completing a postgraduate examination with a little more training, the surgeon should be able to do in the peripheral cities, in the peripheral hospital, a procedure which gives consistently good results. And as said, the primary endpoint of laparoscopic hernia repair is recurrence. And pain and cosmesis are important, but they are secondary endpoints. So I would like to advocate a procedure which can be done by the general masses of surgeons who are coming out of their postgraduate examination. And an IPOM and IPOM Plus, they stand very nicely to this proposition. It is an advantage to keep the mesh outside the peritoneal cavity, but I feel that if you are repairing a defect of up to 4 centimeters, IPOM or even 5 centimeters, IPOM or IPOM Plus, though the time will tell, will continue to play a dominant role in laparoscopic ventral hernia. The more complex repair of putting the mesh in the retromuscular plane, the ETP TAR, the open TAR will be reserved for larger defects, which cannot be nicely closed without tension by an IPOM or an IPOM Plus. So if you feel at any point of time in an IPOM, if the defect is more than 5 centimeters, and it is not just a defect per se, because you are not handling a defect in the anti-abdominal wall, you are handling the patient as a whole. So there will be lots of factors which will decide whether an IPOM Plus is feasible or not, which will include the strength of the muscles, the patient, whether it is thin or thick, whether it is a male or female patient, which is male patient is muscular and female patient has already stretched muscles because of the repeated pregnancy, and they can be more easily approximated by an IPOM Plus, which do not have a fat. So even 6 centimeters in these patients can be easily approximated by IPOM Plus. I would feel that IPOM and IPOM Plus will continue to play a very important role in the future also. And these retromuscular dissections and meshes will be reserved for recurrent, multi-recurrent, large defects, obese patients. The reason given to place the mesh in the extraperitoneal space, to me, does not look a very strong reason, because these tissue separating meshes, I have been using the tissue separating meshes since 1994. And I have not seen any serious complication of these meshes except in few exceptional situations. They do form adhesions, but if the patient does not require a subsequent surgery, then these adhesions do not matter. If the patient requires an additional surgery, then a careful surgeon can mostly obviate, and mostly these adhesions are grade 1, grade 2. They are not serious distal adhesion, particularly because when you put these meshes into the on the anti-abdominal wall, you try to spread the mesh spread the omentum over the mesh. So it is the omentum which goes and gets stuck to the mesh first, rather than the intestine going first. And we have done a lot of resurgeries on these patients who had a previous laparoscopic IPOM repair, and we do not have any reason to regret in our experience of over 38 years. So definitely pre-peritoneal meshes will evolve. Robotic will come into play, and the role of robot will slowly increase, particularly in more complex cases, because the field of abdominal wall hernias has remained dormant for a very long time without any significant advances. And now we are in future going to see very exciting changes, very promising changes. But one thing I always tell my fellows, that every new thing is not an advance.
Yeah.
Every new thing has to prove itself with the passage of time. And I feel that in the current scenario, the ETP TAR are being abused, being used for repair of 3 centimeter, 4 centimeter, 5 centimeter meshes. Because once you do TAR in these patients, and if you do not do a TAR properly, and the patient has a recurrence of the TAR, you are left with very little option. So not only by using these extraperitoneal meshes in smaller hernias, we are making things more complicated, but we are also making things more difficult for a possible recurrence. And we really have to look that, are we doing this any improvement in the treatment of our patients, or we are doing it just because one after the other surgeons are taking a dip in the ETP TAR, and we don't want to be left out, and we also want to have a dip and show that yes, we can also do it.
I agree with you that ETEP is like, let's say, fashion in surgery. You need to do it, but in my opinion, it's very complex, and you do a lot of dissection for tiny hernia, which doesn't make any sense. And another thing that you mentioned is less reproducible. And I think the IPON is reproducible with excellent results. And in my opinion, as you mentioned, I haven't seen problems to these meshes that I've been placing for a long time. And most of the problems that I found have been due to Tackers. And now with the new technique, you can get rid of those Tackers. And this is the advantage. So I fully agree with your comment on this. And I would just make one more comment that I would like to know your opinion is because I have found that in the past, there was some cases that I didn't indicate a minimal invasive, but since I'm doing the IPON Plus and the LIDA, I'm doing hybrid approach. So I'm doing the closure of the midline, very, very good. Then I place the mesh, and if I have a problem with the skin, I remove the skin, and you maintain the advantage of laparoscopic surgery. And I really believe in this hybrid approach. What is your experience or your opinion about this hybrid approach?
I think that in any hernia which is slightly more complicated, which is not an easy IPOM or an IPOM plus, hybrid approach has a lot to offer. You know, these hernias which have facial defects with large hanging skin, bad scar, we see patients who have ulcers on the skin, and these skin are the ones which after a laparoscopic IPOM or IPOM plus repair, the skin has become so huge that it is not going to go back into the place. We are more and more increasingly utilizing a hybrid technique in which you excise the skin. You don't raise any flap. You just close the fascia externally, which is much simpler, which is much faster, which is more accurate, which is more precise than doing an IPOM plus from the inside and then place a mesh inside. So all hernias which are not so small, maybe 5 centimeters, 6 centimeters, particularly if they have a bad scar, if they have a very loose skin, and if there is an ulcer, IPOM, this hybrid technique is definitely going to be more popular because it is easy to do. And the main problem of open hernia repair comes in raising the flaps, which causes seroma, which causes wound problems, which causes flap necrosis. So if you just keep yourself to excising the loose skin and do not raise any flap and cover the rest of the skin and close the defect from the anterior side, it really is very satisfying both for the surgeon as well as the patient.
Yeah, fully agree with you. Thank you very much, Dr. Kriplani, for your answer, your comments, and your lecture.
Professor Mida, sir, your comments before we call it a close.
No, I think we got very good, especially for the young surgeons. There are some controls. You have to have new methods, new devices, so that we hope for the zero recurrence rate and minimal discomfort to the patient. So I think there are some points which we keep on discussing, because as Dr. Conde said, no Tackers at all. So this may not be digested so easily by others at present, but slowly we have to move in that direction. We have to improve our skills, and we have to go on trying to get better materials also, so that the self-gripping mesh and the use of glue, all these are important things which we have to develop in our practice. This has been really a nice session. So should I propose the vote of thanks here only? Yeah. So I thank Professor Conde for sparing his valuable time and sharing knowledge with us. And Dr. Kriplani, thank you very much. Though you were here in Dehradun to attend the FIAGES banquet, but you stayed throughout and shared your wisdom to us. Thank you, Dr. Kanagvel, for arranging this show and always bringing out newer and newer concepts in the prime time. And I also thank our president who has left us now for the banquet. And I thank the prime time team of Doc Plus who have been kind enough to take care of the technical part of this session. And I also thank the delegates who have watched this program. And this program, which was also available on the YouTube and Facebook, will also be available for the viewers who could not view live today. Thank you very much, and good night and good day to all of you.
Professor Conde, I would like to place one request from the side of IAGS. We look forward for a periodical academic interactions with the EAES, maybe once in 3 months or so. Even it can be out of hernia. I'm sure EAS also has diverse interests on various other minimal invasive surgery specialties. So we will write you from an official request. Maybe we can look forward for more academic collaborations. This has been an initiation, and the initiation has been done in an excellent manner. I'm sure academically, India and Europe can do a lot of wonderful activities in the future time. Thank
No
you,
doubt.
Professor.
Thank you.
Thank you very much, sir. Thank you, Kriplani, sir. Thank you, Mina, sir. Thank you, Team Dr. Lecture. Bye-bye, everyone.
Bye. Thank you for the invitation. An honor for me.
It
Right,
was
sir.
a pleasure, Professor Conde, to have talked to you and to have interacted with you. And it was indeed, it was very moral boosting for our delegates who have been watching the program.
Thank you. So I hope to see you soon in person.
Definitely,
Okay.
definitely.
Yes.
World is very small, Professor Conde.
Bye.
Thank you very much.